Hi everyone, this is Deirdre Eberhardt. Today we have on Mark Cantales, LCSW, and he is here to tell us about EMDR. Mark Cantales is an LCSW, which means he does therapy with people. Why don't you tell us a little bit about what you do?
I'm a private practitioner, and among my specialties is working with people with PTSD. Populations that I work with are adults, children, and adolescents.
Okay, wonderful, thank you.
Mm-hmm.
So EMDR, I did tell them a little bit in the intro about what that means. So it's eye movement, desensitization, and reprocessing.
Correct.
What is that?
Yeah. Well, it's a big mouthful, and interestingly enough, it's a bit of a misnomer because the eye movement part was discovered by Dr. Francine Shapiro back in 1989, kind of by accident, and she found that by doing this bilateral movement of the eyes, kind of like you do with REM sleep, that her brain started to process some emotional from her past. And so she started to experiment with this and play around with it. But as the process continued and the experimentation continued, they found out that it was more about the bilateral stimulation. So a better way of just understanding it would be dual attention stimuli, bilateral stimulus therapy. So in addition to the eye movement, you can use ears, you can use tapping on either side, like on a person's right and left leg, right and left hand. So it's really about the bilateral stimulation.
Okay, so I just want to get it straight. So the bilateral stimulation is something where it's happening on both sides of your body,
Mm-hmm.
and by doing this, it helps to process trauma.
Yes.
Okay.
So trauma is, one way of understanding trauma is an event, or sometimes a series of events that overwhelm the brain's capacity to process that experience. And so sometimes people experience dissociation, which means they physically leave their body, right? And it's kind of a cool thing that our brain does. It's sort of as a protective mechanism. So if this is happening to that body, it's not happening to me.
So it's like you're watching yourself, like you're behind yourself watching yourself.
Yeah, or above yourself.
Or above yourself, yeah.
Right. And so because it doesn't get processed like normal events, it might even be sort of scary to us. The brain kind of puts it aside. It's like, oh, I'll deal with that later. Right?
Okay. That
And,
sounds logical.
Right. And so as we're just living our life, different sort of stimulus might trigger, we call a PTSD event, or you can have a dissociative experience, and things that we call flashbacks, where you're essentially reliving the whole experience. It's like it's happening now, even though you're sitting in the living room or wherever you are. And so these triggers can be just about anything. It can be a sound, a smell, a texture, temperature, anything that the brain associates with that traumatic event. And so the brain is kind of always scanning the environment. And so when it picks up on one of these stimulus, it says, oh, well, now it's time to process that. And it tries to process that, but again, it overwhelms the system, and the person dissociates, or they have this flashback or what have you. Other ways in which the trauma might resurface would be through dreams, nightmares, and kind of sort of not a full-blown flashback, but just sort of like flashes, like you get these little sort of snapshots popping in your brain.
Okay.
And even people can re-experience smells and body sensations and things like that.
Okay, so how do we get from this trauma that is coming up and interfering with people's lives to bilateral stimulation? What's the connection? how does it work? Like if I came into you and I said, can you do EMDR therapy on me? Like how would we start?
Well, first we would start by, I would want to make sure that this person had enough resources to handle what we're about to do, because we're going to go back and we're going to revisit this trauma.
So you don't
Right.
jump right in.
No. So, the preparation, we might do some relaxation exercises, some visualization, guided imagery exercises, an EMDR. There's a thing called resource installation.
Yeah.
Right. So I'm going to try to give this person as many tools as I can to sort of get them ready to do the more difficult work.
Sure.
And so it does require drifting back into the past and revisiting the trauma.
Okay.
And really having the person connect with it, not just in terms of the visual image that they have in their mind, but any sensory experiences, a smell, a sound, body sensations. And so, once they get sort of grounded in that, right, it's kind of like if you're on a train and you're looking out the window, you see one image, right? So you have this snapshot of the trauma, right? The most traumatic part of it.
Okay.
And then we would initiate then the next thing that we would do is give them a couple scales to rate that. So, level of disturbance, 0 to 10, how disturbing is this to you now?
So you get a gauge of how disturbed I would be. For example, if you use me as an example, on a scale from 0 to 10, how disturbed are you by this?
Right.
And so if I might say something like an 8 because it's something that I'm coming in for, so it's probably going to be pretty high. And so then you have me bring that up and get into the sensations of it, and then you do, say for instance, if you were to choose the eye movements, the eye movements, moving my eyes left to right for about how many reps do we usually do?
Well, let me back up. I kind of got ahead of myself.
Sorry,
so
yeah.
In the preparation, and in addition to doing that level of disturbance scale, I'd also ask you to identify a negative cognition associated with the trauma. So it might be like, I'm powerless, I'm weak, I'm, whatever. And then I would have you identify a positive cognition. So I'm strong, I'm capable, I'm able, whatever.
Something that you want,
Right.
you would rather think.
You want to replace
Sure.
at the end, right? So that's where you want to be at the end. And then I'd have you rate that on how true is that to you on a scale of 1 to 7. 1 being completely false, 7 being completely true, right? And so this kind of gives us a little sort of marker and measure, so this is our level, this is where we're starting off.
Okay.
Right? And then I'd have the person do a body scan.
Yeah.
So they just kind of like scan their body from head to toe, notice any body sensations, like if there was some tension or pain or, shaking or whatever was going on in the body. And then also identify any emotions that they're noticing. So it might be fear, anger, whatever.
Okay.
And so, I make note of those. And then I have them go back to that image, right? So this is where you get on the train.
Yes,
right?
I jumped ahead a little bit.
Yeah. So you're on the train, you see this image, so this is the snapshot of their traumatic event. And then I'd have them start following my fingers, and I do this, back and forth movement. And as that happens, it's kind of like the train starts to move, right? So the image starts to shift, and their emotional state starts to move. Body sensations might change and shift. I just do that for about 30 reps, and it's mostly like I'm paying close attention to their eyes, and so when a person's like really focused on my fingers, you can tell, they're really intent on looking, and then all of a sudden there's like this soft, subtle change in the eyes. They soften a little bit, and they're still following my fingers, but you can tell that they're starting to process. So that's the reprocessing part. So I'm paying attention to that, and while they're doing that, I don't really want to interrupt it. I want to try to keep that going, but I might, if it, I just might stop, just to sort of check in with them, because they'll kind of soften, and then they, then I can see them like, really focusing on my fingers again, and so then I'll stop and I'll say, what are you noticing? And they'll just make a sort of a brief report, I'm moving through this space, or I can see the person's face. I'm feeling really kind of hot right now, and there's a pain in the pit of my stomach. And I just say, okay, notice that, and just keep going. So each time I check in, they're just giving a brief report, kind of a snapshot, train stop. This is what I notice.
Okay.
Right, and then after about 4 or 5 of those repetitions, I might ask them again to review the scales. How disturbing does it seem to you now? How true does that statement seem to you now?
Okay.
And then just notice that. So if they say, oh, it's like a 7, oh, it went down 1.
Wow.
And that
yeah.
positive statement's more true, went from like a 2 to a 3. Oh, notice that. And then, do another round. And then just keep doing that and doing that. And, it might take, anywhere from, 5 to 10 sessions, typically in that range, before you get the disturbance scale down to 0,
Okay.
and the truthfulness scale up to 7. So it's it's totally true, I'm powerful, I'm capable, whatever. And the way you kind of wrap it up is you just have them do a body scan. Again, notice any disturbances in the body. If there are any, you do another round. It's kind of like we call it the white glove test,
yeah.
right? Until that sort of dissipates, they're feeling relaxed, or the pain isn't there, or the tension is gone. And again, you just do the scales, and if they're still at a 10 and they're still at a 7, still at a 0 until it's still
Then
at a
you
7.
have more work to do, yeah.
Well, no, if they get to a 0.
Oh, if they get to a 0,
right,
yes.
And a 7, so it's
Yeah.
disturbance is gone. It's the statement is true for them. There's no lingering sensations or emotional disturbance in the body. They're done.
Okay,
Yeah.
great.
So, how this contrasts with traditional talk therapy. In essence, talk therapy is the same thing, right? You're holding the person's attention in the present and revisiting a past trauma. So by them talking to you about it, they're hopefully, if you're doing a good job
Sure.
with your client, they're not dissociating or going into a full-blown flashback.
Yeah.
Right.
No. So you don't want to do this with somebody who might go into a flashback. So a good therapist would make sure that you're within that window of you feel okay enough to address this, but you still feel it intensely enough to have to address it.
Right.
Okay.
So, so that's kind of the skill and the art when you're just doing the first part, getting the person to identify the most traumatic part of the experience, right? So let's say, someone was in a horrible car accident, right? There's a lot that happened, right?
Sure.
So if they see the thing coming, there's a skid, there's a crash, there's the noises, there's the ambulance, there's the time in the hospital, there's the recovery, there's surgeries or whatever, right? So all of that is traumatic, right? Trauma to the body and to the brain, right?
Yeah.
And so you can't just assume like, oh, it must be like that impact, that must be it, because no, sometimes it's like, oh, it was the crunching sound,
Yeah.
right? Or the sound of the ambulance, or my daughter crying in the back seat.
Sure.
Those kinds of things. So in that sort of skill of getting them to that place, you're also making sure that you're taking good care of them,
Sure.
and they're not like, dissociating and having this flashback. So sometimes I'll do things like have person, squeeze a squishy, kind of keep them, grounded and present, or we might just even like toss a ball back and forth while they're talking to me. So again, it's sort of like, I'm going to keep you here in the present while you're going back in your mind. And essentially the EMDR process is just that. So by doing the bilateral stimulation, in other words, kind of lighting up both sides of the brain, it keeps a person in the present, so they're not dissociating while they're sort of revisiting this trauma.
Yeah, I know I've had people who they seemed okay going in, we did all the preparation, and then they start to dissociate. And so what I have people do is I have this bowl of crystals that have been tumbled, and so they get to put their hands in it and kind of play almost like a sandbox, and I have them look out the window, open the window, feel the cool air on their face. It's because you don't want, the idea is not to re-traumatize somebody.
Right,
it's the exact opposite. It's to process it so that it's not such, something that's just like right in front of your face. So that's how I like to tell my my people who I help with EMDR is it's not that you're going to forget what happened, or you might even still have extreme emotions about it, but it's not like it's happening right in front of your face anymore. It's almost like filed away into the correct parts of your brain.
Yeah. And people report oftentimes is that they know that it happened, but the image is kind of fuzzy and blurry, like they can't really even access it real well, but they like, oh, I know this happened to me, but it's not as like vivid and sensory rich as with the trauma.
Right, which is what causes the interference. Now, for people who have had no major traumas in their life, could they also benefit from EMDR? Are there other things that you could use EMDR for?
Yeah, there's been some work with phobias, specific phobias that seems to be efficacious. Also, people with panic attacks, which is also kind of it's a fear-based kind of a thing. And people are experimenting with it.
Sure.
I have done it with people who had phobias, like school-based phobia. And it did help. So yeah.
Okay. Yeah. It's all very interesting. I've been to the EMDR trainings, and I've asked a few times, and they keep telling me no, but you should do research on it. I'm like, okay, I don't know when, but I ask, what about drumming, and they said there's no books out on it or anything that connect the two, but bilateral stimulation with the hands, I don't see why that wouldn't be an amazing tool to use for EMDR. So there's lots of different interesting things that we might be still learning.
Yeah, I know that kind of in the EMDR world, that there's a very specific protocol, as that you're supposed to follow, and I understand that because it's it's 30 years old, so it's still pretty nascent, as far as treatment.
Okay, picking back up. Sorry about that.
Yeah, sure.
So we were just talking about.
I was, it's pretty, EMDR is still fairly new in terms of treatment modalities, and so people are experimenting with it and trying different things. Like for instance, I was saying like I've used it with people with phobias and stuff like that.
Sure.
Anxiety. So the main thing is that by continuing to follow the protocol, you can say that the bilateral stimulation technique is being implemented.
Yes.
Right? Because there's some controversy about the treatment in our field, and because it's partly because we're not really sure how it works.
Sure.
You know, our best understanding of it is that by keeping both the left and right hemisphere activated through the bilateral stimulation, that allows the trauma experience to kind of slowly get processed instead of all at once, right?
Yeah.
So it doesn't take over the brain or hijack your hippocampus,
Yeah.
right?
Yeah.
And so for me the proof is in the pudding.
Yeah.
That when I use this technique with people who had severe trauma or a history of multiple traumas, and we see them clear away, and they're like, wow, this is like magic.
Yeah.
Right.
You see it working over and over and over again.
Yeah.
It's very similar to how people use medications for mental health.
Mm-hmm.
We know that they work. We don't always know the exact reasons
Mm-hmm.
why they're working. We kind of have a general idea.
Mm-hmm. Mm-hmm. Yeah.
So wonderful. Thank you so much.
You're welcome.
Yeah. So thank you, everybody. This has been very informative. And thank you for listening to and watching The Mental Well. Go ahead and hit subscribe if you're watching on YouTube or on listening on iTunes. This has been Mark Cantales, LCSW, therapist and EMDR practitioner. Thank you so much.
You're welcome. Thank you.
Thank you.